So nurses come in fours. So good afternoon. This is our last presentation of the day, so hopefully we won't keep you too long. We're going to be talking about sorting out sepsis, and it is actually a pun because our team is called SORT, so Sepsis Outreach Response Team. I'm Amy, I'm the matron, and I cover outreach, rehab and sepsis. I'll let these guys introduce themselves as well.
My name's Helen, I'm Halsall, I'm one of the senior sisters at Walsall Manor.
Hi everyone, I'm Laura, I'm one of the senior sisters within the team.
And I'm Xana, I'm the senior sister and I cover rehabilitation, sepsis and outreach.
So why did we need a sepsis team in Walsall? I saw Sean here. Sean helped us because we stole a lot from Dudley, but you know. So why did we need one? The CQC came to see us and they saw that there was gaps in our sepsis management, and we were challenged that we needed to ensure that we had robust ways of managing sepsis and we could assure safety for our hospital. So lots of people thought about who would have the sepsis team because sometimes it sits in a resource team, sometimes hospital at night were thinking about it. But as an outreach team, we were already seeing sick patients, we were seeing newses of 7, clinical concern. So it seemed kind of fitting in that a lot of our patients are septic that go to ITU. So we put a bid in to get the sepsis team. And starting out, we noted that our first lot of antibiotic compliance was 56%. And we were at 91% now compliance for antibiotics within an hour. And we were 28% on the complete sepsis 6, we're now 70%. And that is purely on a digital platform. So we took paper out of the hospital because you can't really audit paper. And we went straight on to embracing Vitals, which was very difficult. If any of you are on Vital Pack, it's a bit of a nightmare. So background-wise, we are all ITU background, so all work within an outreach service, not all from the same outreach service prior to the team starting. And ITU skills, we've got our ITU course, Red Content Prescribing. Yeah. So the aim of us was to improve early recognition of sepsis, standardised care and enhanced outcomes for safety within the hospital. What we thought our team would be is not exactly what it ended up being. We thought we were going to be a purely clinical team and it was going to be just like outreach. Everybody was going to ring us and they was going to be so happy to see us because we was going to get the sepsis 6 done. It's proven to be slightly more difficult than that, so we've had to channel various ways to engage with staff, including education, kind of going towards and making champions, but we'll talk about that. Is that you, Xana?
So I feel like I'm at karaoke, so I do apologise. So why a sepsis outreach response team? So like Amy's just said, we're already clinical. We wanted to be there at the face of it. We didn't want to be just an audit team. We wanted to actually go out there, support people and actually support our doctors, support our nurses and just take part in the action on the front line, basically. So we're all upskilled anyway, being ITU background. So we go out, we do blood cultures, we take the lactates, we do the ABGs. Majority of our team now all prescribe, so we don't always need, we do need doctors, but we don't need doctors to activate the septic 6. So, and working within the MDT, we're already a well-recognised team without the hospital, we're all really approachable. We're never a stupid question and we find that people do come to us more, so we're finding that we are closing the sepsis 6 a lot quicker.
Yeah, so prior to us, some of us are outstanding on prescribing. I think there's 2 people. So we have got a PGD for only neutropenic sepsis. We couldn't have a PGD for antibiotics on a whole because there needs to be some governance and actual respect for giving antibiotics. But if you've got a plain neutropenic patient, then you know you're going to give tazocine 4 times a day, or you're going to, if they're antibiotic resistant, there's pathways for that. So we have got a PGD for that.
So team sits. So we've got a matron, we've got 5 band 7s, and we've got 3 band 6s. So Amy, who's our matron, she still works clinical shifts, which we find really important, and we can't get her away from it because she loves the clinical side of it still too. The band 7s, only the band 7s do the sepsis, and we all work on outreach as well, but we tend to concentrate on sepsis, again, because of having the V300 and completing the sepsis 6, but we do still do outreach shifts as well. And then we have 3 band 6s that work alongside us. Our team is 24 hours for outreach, 7 days a week. Sepsis currently is only 8 in the morning till 8:30 at night, but it is something that we're working on a business case to get it 24-hour service as well. But you know what the money's like currently in the NHS, so that's something that we've not managed to achieve yet. But we're finding that a lot of our, when we come on in the morning, a lot of our sepsis, we are having to close in retrospect, so we're collating that data to support us to get a team to night time, so we are closing them within the 60 minutes.
So implementation strategy, we decided to first look at audits that we had available within the trust. This helped us to establish a baseline of where we were at and then help us to move the team forward. We then developed a SOP, which helped us to look at evidence-based practice and protocols, which guided the team forwards. A big part of our job, we thought, would be to be working within the multidisciplinary team. So within that, we looked at working with the microbiologists so that we had up-to-date antibiotic guidelines, the infection control team, oncology, as Amy's mentioned before, with neutropenic sepsis. And as we all have a critical care outreach background, we then put ourselves as part of the medical emergency team within the trust. So we're there looking at patients that are deteriorating, and with our presence we are sort of saying and asking the question, could it be sepsis, and prompting people to open the sepsis 6 and complete the sepsis 6 actions. Within the team then we had a new bleep so that we had our own way of being contacted. As you saw in the pictures, we went for a uniform that we could be recognised, which was in
They
red.
made us look slightly ridiculous in red.
I feel like a tangy tom.
But we stand out within the hospital because we are the only team in red. And then we looked at how we could launch. So our launch included partaking on stands. We had our own posters. We had like credit card size cards that we handed out to different members of the team, which gave like the sepsis 6 actions, our bleep number, just to keep prompting and reminding people. We then looked at attending study days within ward areas, doctors' inductions, and then we then looked into IT, and with IT we launched the Vital Packs, and with the Vital Packs we've got an element which is sepsis, so anyone that's triggering a 5 and above or 3 in a certain area, the Vital Packs will prompt the person to think about sepsis and open the sepsis 6 checklist. We then are doing trawls and looking for open sepsis checklists, which will then guide us to the patients, and then we can pick them up and help get those actions completed. On the back of that, then we have the sepsis 0837 report. This then we pull on a daily basis, and this is sort of gives us a safety net really, because obviously we're not a 24-hour service, but it gives us all the data of sepsis checklists that have been opened within a 24-hour period, and we then go back and back through retrospective data, which has helped to improve our figures.
So it's the back end of Vitals. So you only see the front end when you go onto Vitals Clinicals. You'll see your sepsis 6 that's opened. This is pulled by the back end, and it'll show you where the patient was, why did the trigger, what they had done, and where they've gone since. And so then we can sort of check on these patients, especially if it happens of a night time where we're not in post. So we can make sure they've got what they needed, they're escalated or de-escalated as appropriate, and just check safety-wise. Vitals isn't perfect, it still uses Q-SOFA, and it does use that 3 and 5 for sepsis, and we know the new NICE guidelines are much different, and it doesn't embrace the new NICE guidelines, so it still aims for a purely, you're going to do sepsis within the hour, so there is some difficulties with Vital Pack. I've been promised it's going to be fixed by September, but we will see if that does happen.
A big part then of our role as the sepsis nurses, we looked at education and training and how we could get out within the trust. So one of the first things we looked at was being part of the basic life support BLS sessions that are put on by the trust. This not only helps us to look at the trust level, but we're also looking at a community level and getting the community staff to think about sepsis as well. We were asked to teach on the AIM course, and we look at the sepsis part of the AIM course. CSW training, we decided that this was really vital because obviously the CSWs are the patients on a frontline basis. They're the ones that know if they've gone a bit confused, what's normal for the patient. They're the ones emptying the catheters. Is there a change in the smell of the urine? They're there with the wounds, etc. So we thought that involving them would be a good way forwards because obviously they can escalate to their nurses in charge. And then along with CSWs, we thought about involving the student nurses and the junior doctors and being part of their rotational and starter weeks as they're inducted into the trust. And then for the senior doctors, we got asked to teach on the impact course, and there's an element of sepsis within that with case studies, and we then bring it to life with like real life scenarios of sepsis. We then think about moving forward and having some governance, so we got ourselves involved with the deteriorating patient group and the working group sepsis, just so that we had more of a stance on directing sepsis within the trust.
So real-time data, this is what the trust needed to be able to provide. We are part of 2 hospitals, so we're a combined trust between Wolverhampton and ourselves, and they decided that 90% of patients should get the sepsis 6 within an hour, so 90% should get antibiotics. Unfortunately, that doesn't take into account the new guidelines, because new guidelines would give you 3 to 6 hours, with your lactate being the severity predictor. So if your lactate's high, then you're going to go ahead with your antibiotics, because you're going to look at diagnostics first in the cases that you can. But if we're going to look at pure what is around, so antibiotics within an hour, this is from Sean as well. I feel a bit like I'm not sure. Sean sent me this and I've used it blatantly. So antibiotics, this is a mean antibiotic, so 64.8. We're sitting at about 90%. That's not self-audited. This is purely on what our computer's giving us, so this is purely on VitalPack. But we have to understand that there's an element of, are we actually causing a little bit of harm maybe if we are giving 90% of people antibiotics within an hour? So that's always on the back of our mind. But also we need to look at our ICU admissions. So this is our ICNART data. So this is an intensive care audit. So down here is all like trust. So same sort of size. We're an 18-bedded unit. And we can have 18 level 2s, 9 level 3s, yeah? And so we should be sitting in this nice sort of middle grey area to show that we're actually compliant with our trust is safe. Prior to starting, you can see that there's some amber areas, so this was prior to our hospital starting the sepsis journey. And that was late sepsis admissions from the ward, missed triage for sepsis. This isn't post, this is a brand new one. But post-implementation, it was green. So sepsis trust came, the sepsis team came, and the next quarter, we were green. So that gives you some assurance, but it was on the back of COVID. So we started on the back of COVID. We were 500% capacity during COVID. So then was it green just because we've not got all these patients, 500% of patients that needed ITU, and was leaving them on wards because we had no capacity? So now we're 3 years down and we're still green. So we have taken that as assurance that the patients that get into ITU are the patients that need to get to ITU. We still take part in the deteriorating patient sequencing. It's not mandated, but we still do take part in it because it asks really good questions about the patients that do score high on wards. Have they got plans that were acted within certain time frames? And I think we're sitting about 88% on that as well, so we're doing well with that.
So, with any change, implementation in change, you're going to face challenges. It happens all the time. One of our big problems was raising our profile. Now, we're walking around in a red uniform. Can anybody guess what we were mistaken as? Infection control.
Yeah.
Blood services. Yeah, we...
Actually, so when we started, we had to wear masks still. And this elderly lady who works in the hospital said to me, "What are you?" And I said, "We're a sepsis team." And she looked at me really disgustedly and she walked off and she come back and she said, "What are you?" I said, "A sepsis." She thought I said sexist team. and they just put us in a red uniform to be sexist.
Yeah.
So, you know, we
Yeah.
have been mistaken for quite a few things, actually.
We've had people hiding cupboards thinking that we're infection
with
control.
a cup of coffee.
So, yeah, that has been one of our issues, is raising the profile of the team. As well, because we do cover outreach shifts, they think we're outreach when we are covering the sepsis side of the roster. Embracing the new sepsis guidelines, obviously we're aware that vital packs, or if anybody that does use vital packs doesn't recognise the new sepsis guidelines. And also, with the beauty of technology, it doesn't always work. So sometimes our sepsis triggers don't always come through as live sepsis triggers and we're not catching them. The team bleep has also been one of our top issues because we are known within the trust and everybody knows us as outreach. They automatically bleep outreach first. So the outreach team, well, the girls in the outreach side will just redirect the bleep to the sepsis bleep. Compliance with wrong antibiotics being given, which I'll touch on shortly. Also getting medics to complete the sepsis 6. On the right side of the slide, you can see where the feedback has been given from the medics, and it's, you know, lack of senior support, time pressure on calls, time to delivery of antibiotics and fluids. So there's multiple there for you guys to have a read, but that is one of the big issues from the medics.
Yeah, they find that they'd start ward round and then the consultant could say, "Oh, this could be sepsis, did the sepsis 6. But then the consultant would want to carry on the ward round.
Yeah.
So then 2 hours later, I know that people don't think the Kumar study is that it's not 100% accurate. But if you're looking at mortality of 7.8%, you're kind of looking at almost 16% mortality rate in after 2 hours of not giving antibiotics. But a junior doctor is not going to challenge a consultant. So it's kind of finding the areas where they are pressured and then getting them to utilise us.
Yeah, absolutely. We also found that blood culture training was low within the trust and paper copies were still being used. While they're being used, we can't audit and we can't also find those triggers when they are live. Also, we don't have a foothold in A&E. We cover everywhere else but A&E. And we do find that A&E like to discharge their patients and not close the checklists, which then has an impact on our percentage rates. Change in staff circulation, retirement, new starters, people going off sick, and as well just sickness within the team and the shifts not being covered are the challenges that we've faced so far.
Oh, sorry.
So, solutions. We focused the training, as Helen kindly mentioned earlier, and we upskill the staff to make sure they've got blood culture training. We also did an audit with the microbiologist and we found that 20% of the patients were on the correct antibiotics, and the result in that followed that 80% of the patients.
So finding the areas where looking at differential diagnosis compared to the diagnosis on admission, so the difference in A&E to actually being the first antibiotic given to the change of antibiotic, and then working with these doctors, actually giving the right antibiotics, using your microguide. Don't just... I was teaching a med reg the other day who told me, my hospital, I give meropenem to every patient that comes in. And so it's about being responsive and sort of doing your diagnostics first.
Yeah, definitely. We're upskilling the team, as Xana mentioned earlier, so that we'll all be prescribers as the Band 7s. Again, vital packs, IT, what can I say? You're always going to get issues. We've got a good relationship with IT and they will help fix our reports and any issues that we've got going on with the IT services. Ensuring the risk register is up to date with any gaps and identifying areas of non-compliance. Also,
I've gone back.
You've gone back. Actioning any Datex incidences that we receive. Also a solution that we've come up with of recently is putting on some bite-sized learning for staff, in person, direct on wards, as well as their e-learning modules. And live sepsis triggers will be covered by outreach if our shifts are if the sepsis shifts aren't covered that day. So lessons learned, all MDT need to be involved. The benefits of CSW training, you know, they are seeing the patients on the wards. Like one of the girls mentioned, they know the patients day in, day out. They can see a change. IT reports, etc. Working together is the key to get the treatment completed in time. Understanding it's not just about antibiotics, but it's about the correct antibiotic that's being given. And just really, we've found that teaching across our trust has made the biggest change. You know, you see the percentages that Amy showed you, it is huge. So it's just constantly, you know, making sure that people are compliant, they're doing the refresher courses, and there's no issues really. And as well, lastly from my side, lessons learnt from an M&M are meaningful and impactful, and they will make changes. Amy wanted to mention.
So one of the things in our trust is we weren't robust in neutropenic sepsis. We'd had a learning from death, and it was unfortunately a person with curative cancer that came in, and it highlighted that there was a big gap within the division of surgery, that acute oncology weren't following the patients up daily. And so the neutropenic guidelines weren't known within surgery for our trust. So the person didn't have bloods for 3 days. So they went from normal neutrophils to 0.0. They went from not having the correct antibiotics. They had bisoprolol given for a high heart rate. They weren't, it wasn't identified a temperature spike because it's different with neutropenia. And so we, with oncology, have put a really robust plan in. Now that oncology see patients every day, it doesn't matter what division they're sitting in. All of their documentation is in red paperwork with the neutropenic pro forma. And we've done a lot of teaching about neutropenic sepsis, especially to the new doctors when they come in. And as we say, we can also, even the people that can't, including our band 6s, can give neutropenic sepsis treatment.
So moving forward, the main thing that we need to do is increase our bleeps. Like you say, we know these doctors are under pressure, they still don't bleep us, no matter how much we keep trying, so that's our main thing. Continuing to work with our IT systems. We're currently still on paper, everything in our trust, which is a nightmare. We're on about going on to electronic prescribing, which will help significantly as well, and then help with our new sepsis guidelines as well. Continue to work alongside microbiology. We've got a really, really lovely, approachable team within Walsall, and they're happy for us to contact them as well and to continue to work with those to improve and to keep doing the studies that we've done. Like you say, to increase our antibiotics to 80% was excellent. And continue to upskill our workforce as well, and that's not just within our team, that's within the hospital, because obviously the turnaround within NHS currently is absolutely humongous, isn't it? You can't keep staff. As soon as they come get the ITU course, they're all going somewhere else, aren't they? So just continue to upskill our own teams, and obviously the future of the workforce as well.
And it's finding new ways to upskill people. We're not in a current financial position where you can put massive study days on and release teams from wards. So we've come up with solutions like our PEFs take over the ward area, so they will look after the patients to release the nurses to us. So that way there's actually somebody looking after the patients, and then somebody...
We've just put it's only a 30-minute presentation we do, and to be honest, we don't present to them, we just actually sit and talk to them, and then the PEFs will go into the bay, everybody in that bay will come out, and then they'll go and look after the patients for us. That's something we're just starting now as well. And as anyone that's in an outreach team currently, call for concern. So call for concern is linking quite nicely in with sepsis. So we're just starting our wellness rounds at Walsall. So this is about going back to basics. I heard someone talk about earlier about going back to like respiratory rates, and also actually looking at your patient, listening to what they're telling you, and actually touching your patient again. So we've relied so heavily now on technology that we're not actually like looking at what the respiratory rates, how they're breathing, looking at like touching them, and just going back to soft signs. So we've got soft signs and our new our paperwork, which is actually on paper just for this, only because it's a first like rollout. Everything else is electronic for this. But like I say, going back with our CSWs again and teaching them about soft signs and knowing what the back to basics, like when we've qualified 25 years ago. I'm showing my age now. So just going back to that.
Yeah, so because we all know that news is very flawed, 15 litres scores the same as 1 litre of oxygen. We used to feel pulses when you was doing your observations. It's really hard when you're on an iPad and you just put in obs in and you've got a time frame to do it, else you're amber. And so this is actually having meaningful conversations. We're rolling it out so it's done during ward rounds. So the surgeons, we're doing 1 surgical ward initially and 1 medical ward, and it'll be also asking, do you know your plan? And I think that will hopefully reduce a lot of complaints within our trust as well, to have these meaningful conversations, have 5 minutes to talk to the patients. So conclusion. One of the messages really is don't be comfortable in your role. We've had to really change and push ourselves. So it's quite comfortable to sit and not get bleeps and get 90% antibiotics within the hour, and then you'd have a lovely day at work. But that's not the right thing to do. So it's how can we be responsive to our hospital and we can ensure that we are providing a safe, effective service. So I'm always pushing them to make new plans. And we've got a happy mail trail at the moment. I'm not sure it's very happy. And then be adaptable and grow. Be aware of the bigger picture of antibiotics. This is one of the biggest things. We know the 5-year plan, the 20-year plan, that we should be looking at reducing antibiotics. We need to be aware of surveillance, reducing antibiotics in community. And then as well, because we have got the umbrella of rehab, so Xana started the entire rehab service that we run. Looking at these patients and what is the financial burden, what is the recovery from sepsis like. You'll have patients come in that will never go back to a normal life that they had previously. You've had to refer a lot to financial aids and things, haven't you? So understanding the bigger picture, it's not just the person in front of you right that second, as part of our team anyway. And now you can community services. Hospitals are really busy at the moment. I don't think we use our virtual wards as well as we could do. So if you have somebody with a catheter who's been in 5 times this year, put them under the see if they can go under the frailty virtual ward. Get antibiotics in the community. Don't come via the front door. It's not fair when a 90-year-old's, stuck in A&E for hours. And I think in conclusion, I've got a lovely microbiologist. And he said to me, he says, the conversation that I think we'll be having very soon won't be that my relative died of sepsis. It'll be that my relative died because I couldn't give them antibiotics. We haven't had a new antibiotic since the 80s. I know that there is always ones working in the background, but be really responsible about what you're giving.